Don't start the timer till I'm on. And the clicker. Okay, can you hear me? Good morning, everybody. Wow, it's a tough crowd, huh? So it's very hard to come after such a long and very long list of very, very qualified speakers. So I really hope that I can bring something else to the discussion, bring another perspective. And that perspective is an international perspective. As Raphael said, I work for the World Health Organization. I'm a medical doctor by training. But before that, I was a journalist. And hence, whatever job I'm given in WHO, they keep pushing me towards communication, risk communication, training, and so on. So if I appear odd to you professionally, that's the reason for it. Okay, so here we are. Oh, I see, it started, the countdown. My God, I'm so excited about that. Okay, so what are we going to do? We're going to, in the next 15, maybe a few more minutes, do three things. We're going to look at international frameworks and agreements and law that actually frame risk communication. We're going to highlight challenges, and particularly systems challenges in emergency risk communication capacity development, and based on our experience, propose some ways forward, right? You see has anybody seen this movie, Contagion? Yeah, I had the pleasure of working with Steven Soderbergh for that. Yes. And when he came to WHO and said, would you like to be an extra in my movie? And I said, do I look like an extra to you? All right. So the crowd is getting a bit warmer. Okay, here we go. All right. So the three big ideas is, as everybody has said so far, this century poses unique challenges for us. Whether it's a fact that more people have access to mobile phones than they do to save toilets, right? The proliferation of technology, travel, and also the technology with which to create microbes as well. So it's, there are lots and lots of new things in this century. We have learned lessons from the past, we have. But I always caution that not every lesson from the past fits the future. And we tend to spend a lot of time learning lessons for past epidemics. So I think it's very important to be able to filter out, as I think it was you, Professor, said yesterday, we can take strategies for the future, but maybe not the tactics. So I would like to caution about that. And then I've got some small text about what we should do, which I will come back to. All right, so we've had different perspectives on emergency risk communication. I am incredibly pleased to see that a body of scientists, biomedical experts, and others are talking about risk communication, community engagement. 5 years ago, this was not the mainstream thing to do. So that means we have all moved forward. So what do we understand by risk communication? My interpretation comes from the international health regulations. And it's really how we understand it is not about telling people what to do, but an exchange of not just facts, but opinions, of views. So this multi-directional communication between people who know or who are responsible to act and those people at risk. And the point to remember is when you are the authority and the expert and you're also at risk, that is the moment you realize what you say as experts don't really matter to you as a person at risk. I was in the tsunami of 2005 in Sri Lanka, 2004, 2005. I was in the response when over 24, 48 hours, I realized 50 members of my extended family had died. And your perspective in responding, when you have personal loss and personal risk, is very different from you sitting in Atlanta or Geneva or DC. So this is really important. The purpose isn't to tell people, but it is so that people have enough contextualized, appropriate information to make their own decisions. And their decision could be, no, I'm not going to follow the advice. No, I'm not going to be evacuated. No, I'm not going to take the vaccine. That is possible too. And it covers all the domains that we've covered here, all the way from mass communication, first announcement, media communication, all the way to community level dialogue and community engagement. So the field has become very, very complex. In WHO, we look at the health promotion sort of model where the individual is seen within the family and community, using services, being affected by the political, legal context, right? And of course, something will happen. There'll be public information, there'll be mass mobilization, there'll be engagement, and the output has to be that trusted, appropriate information reaches those at risk. The outcome that we desire is that they take the right behaviors, the protective behaviors for themselves and their families, and of course, contributes to the public health goals, which is to control the epidemic, to stop it as fast as we can. So we know through the years that systematically risk communication has a role in every stage of infections, from the emergence at the animal-human interface. For example, in MERS-CoV, still in Saudi Arabia, it is still about the interaction between camels and people and their cultural interactions, the value they give to their herds. Rift Valley fever, it's the same. Avian influenza, it's the same. Early detection, containment, mitigation. So it's becoming layers and layers of complexity. In 1948, WHO's constitution, I really like this constitution. That's why I've been there for 15 years, WHO. Every time I want to leave, I read the constitution and I get very excited, right? Because in 1948, they had the foresight. The constitution had the foresight to see a world that respects human rights, that appreciates interconnectivity. And it saw the participation of the public as central to dealing with health problems. Not the benevolent, we know you do, but really you need to participate. The international health regulations, I'm sure many of you know, have their roots in the first wave of globalization when the big ships took Europeans and to Asia, Africa, and brought back diseases to which their communities had no immunity. And it was on those ships, the ship's captain, if there were people sick on board, would put up a flag. Which color? Yellow. Yellow flag, absolutely. To warn people, you cannot get on, you cannot get off. And that's actually the color of the visual images of international health regulations. It developed to detect and respond and mitigate international transmission of diseases. So we don't want the international spread of diseases. In 2005, there was a great appetite to revise the international regulations because SARS taught us that it wasn't just health at stake, but it was travel and trade and economy and so on. So actually health became a very political issue. New players came into health. It wasn't just old ladies like myself doing public health, barefoot doctors, that kind of thing. It became a very sophisticated sector. And in the international health regulation, risk communication is one of the 8 core capacities that countries should have. I will answer some of the questions of the previous session as well. How well have we gone there? Then, with pandemic, there was something called a pandemic influenza preparedness framework, which looked at the exchange of materials, say, for example, virus sharing. So when Indonesia had the new virus, they were supposed to give it to WHO, and we were supposed to give it to the pharma, and the pharma was supposed to develop vaccines for the world. And Indonesia said, hold on there. We'll give it to you, you'll give it to them, and they will charge us for the vaccine for which we have intellectual property rights. So this whole discussion about sharing risks and benefits started. And in that, one of the 5 preparedness areas is risk communication. And I run that as well. And of course, there are program strategies, whether it's immunization, whether it's child maternal health, where risk communication has been used for a long, long time. So it's not a new idea. This is the first Director General of WHO who was appointed in 1948. He saw that there were barriers such as superstition, ignorance, religious intolerance, misery, and poverty that actually framed how we would be able to deal with microbes. So on the one hand, we may develop technology against the microbes, but we still have all these social constructs and political constructs that affect us. So this is, as I said, I still remain in WHO as long as this constitution remains appropriate. So what have we learned? What have we learned in the last few big epidemics? And we've learned a lot because communication has been so open. Since the tsunami of 2004, we've had citizenship journalism. We've had every disaster and epidemic brought into our sitting rooms, right, into our families. So really, everybody seems to be more aware since that period. So when the Spanish flu killed 18 million people, it was you got sick, you died, right? There wasn't much else. SARS really talked about the economic impact, but also gave people the impetus to protect themselves, right? So people were wearing masks, they were doing all sorts of things. And the present, with the high-speed travel, with our interconnectivity, with vaccine hesitancy growing, although we have public health tools, but resistance to this growing, we see a very, very complicated world. So SARS, don't ask me why some of the circles are empty. Okay, this is how the program came out when I did it. It has no meaning because people ask me this in conferences. It has no meaning. But SARS was big. The size is quite right. It was big because this is how we understood epidemics are not just for health people to deal with. Right? So this became very important. Pan flu was decidedly underwhelming and a lot of criticism to WHO suggesting that this was not a real epidemic. There were lots of reputational risks and hits that we took. MERS-CoV emerged. Luckily, it's not as transmissible, but because it's a respiratory disease, we have to be very careful about this. Ebola, I think, changed all our lives. Ebola really did, whether you were in West Africa or not. It really changed the way we saw the world. MERS-CoV, again, Korea. People have a habit of hospital shopping. They go from one hospital to another. And the government was not able to announce this and publicly declare where the epicenter was for various reasons. Zika, it's tragic to those who have it. A lot of other people have decided it's not very important. We tried to push the message of reproductive health, sexual health, in a region where the Pope had already given the key message that family planning is evil, that abortions are evil. So how do you compete with that? It's very difficult. And yellow fever. So yellow fever, people of Angola, below herd immunity, under 80%. People were supposed to be vaccinated, not enough were. And then we had this outbreak which spilled over into the Democratic Republic of Congo. I manage also, as part of the interventions, global stockpiles of vaccines. We had 6 million vaccines. This was already a success story. Yellow fever vaccine 20 years ago cost more than $100 per shot. Because of technological transfer, in part facilitated by WHO, the cost was $2.50. Even this, we couldn't vaccinate enough people. We had 6 million doses, we needed 30. Within a matter of weeks, we were able to come up with a new composition and vaccinate the government, supported by the international community, UNICEF, Red Cross, WHO, and others, 30 million people, and stop this outbreak. And we learned a lot about risk communication in that. Before, our risk communication was one vaccine for life. In this, we had to say one vaccine for 1 year, and you can't leave the country. So that was tough. So what did we learn? And this is a recap of what many of you have said. We need to create and maintain trust, communicate even in uncertainty. I'm not going to go into that. I think many speakers spoke to that. Another speaker mentioned this, and I like this very much. We need outcome-based communication, not message-based. If you start with messages, I can assure you, you will be 99% wrong 99% of the time. You can find 1% of the time where this message works. But no, you have to figure out what the situation is, what you know about the risk, contextualize, look at the outcome you want, and then create messages. Cirque has some good tips on what to do in crisis communication. I like alliteration, so I say be first, be fast, and be flexible. Be damn flexible. That would be the adjective that as Juliet said, we said Ebola kills. Well, if Ebola kills, why should I bring my loved ones to your Ebola treatment unit where you will gobble them up, cremate them without me knowing, right? So it's very important. No mosquito, no Zika. If you live in mosquito-infested countries, you know how difficult it is to get rid of mosquitoes, right? The government of Singapore spends $4 per person per day for vector control, and they're successful. I challenge any other government to do that. I come from Sri Lanka, the mosquito. I'm very, very careful in the first 24 hours. The third day, I've forgotten about it. Use integrated approaches, and we've really, everybody so far has talked about using social science techniques to listen, to understand, to work with communities, to co-create with them the solutions that work for them. Coordinate partners at all sectors and levels. Somebody asked about this. This is the nightmare of operations. Everybody wants to lead. Nobody wants to follow. Everybody has their opinion. I mean, it's too crude to say it in a place like this. I have a phrase for it, but I can't say it. And this is awful, right? Beating their chest. A lot of boys as well. Girls tend to behave better in emergencies. A lot of chest beating. I am in charge. I apologize to the nice men in the audience. So we had a lot of trouble when towards the second half of Ebola. Then when the coordination mechanisms were set up, that worked. In WHO, we have an incident management system. So whoever's the incident manager, even if he's lower than me in daily life, I have to listen to that person. So that's a very good thing. In Zika, UNICEF and WHO and 120 others coordinated from very early on, because we were tired of not coordinating well. And for the first time, for Zika, we decided we would set one set of recommendations and messages to the field together. UNICEF, Red Cross, WHO, so that we don't confuse our stakeholders at the field. So build national capacity, we're going to talk about that. It is not about us replacing anybody. We need to have surge capacity. I'm not saying we don't, because for big emergencies, national capacity will always be overwhelmed. But the predominant strategy is to build national capacity. And the second strand is for us to be prepared to help in the most helpful way, right? And then assess the capacity and test through exercises. Ed and I had a little conversation yesterday. Basically, people who train together, do simulation exercises together, are very happy to work together, right? So for anybody who's divorced, you should have done that with your ex-husband or wife, all right? Before you got married, all right? And we need systems capacity to do any or some or many or all of these types of communication. I am sure that none of you, even if you're a communication expert, can do all of these 16 types of communication. I know I can't. I pretend to do about 4 or 5. I'm probably good at 1 or 2, right? My strength is I know when to get out of the way. This is my only strength. But look at the complexity of what we need, right? So we need people, we need training, we need capacity for all of these things. Political communication, briefing decision makers at short notice is the critical step, right? We train, and I'm sure you do too, health sector. But when something big happens, the health sector is just so low down on the food chain. Right? The military takes over, the president's office takes over, and you suddenly have people you've never communicated with. So the ability to do very quick political briefs at times like this will help in the response. So I'm going to share only 2 pictures, personal pictures, to illustrate the systems issue, okay? This was taken by, I have 150 communications experts who can be deployed within 48 hours to any emergency. This network has an 85% annual deployment rate. It is very, very operational. This is a picture taken by one of the first people I sent, and this is in Sierra Leone. And this tells the story. This tells the story of Ebola. Finally, the white bags are being used, which is the color of mourning. You see there's men there, no women. This is a Muslim community. The women are on the hill on that far side. You see, some people are completely protected. You can't even see their faces. Others are completely exposed. And these dynamics and these hierarchies played over again and again and again. And there was, unless you have social science training, you are an anthropologist, or you're just from a poor country like I am, right? Where you've been the underdog. It's very difficult to see this. We see it, but we don't understand what is going on. And this one is me, because this is one type of communication I didn't put. This was in Nigeria, Port Harcourt. 2 minutes before this, This was a stadium filled with 15,000 teachers. So everybody used their radios, community radios, said, come to this stadium tomorrow. We're going to teach you to open schools again. 35 million Nigerian school children were supposed to go back to school the next week. So the teachers came into this stadium. Nigerians are very tall. I had no heels on. I was very short. I was at a disadvantage. I'm sitting at the back of the stage thinking, okay, I'm just observing and learning. 2 minutes before this, the Ministry of Education puts 2 people on the stage and demonstrates how to put on and take off personal protective equipment. No messaging, nothing. So now 15,000 teachers think they need PPE in order to open schools, right? So the agenda was thrown out. The minister said, you go on. I said, I wasn't scheduled to speak. No, you go on and sort this out. So even without the heels, I thought this is a stadium. So I channeled my inner Rihanna. And I said, good morning, Port Accord. And they roared back. Nigerians are very interactive. They roared back, good morning. And I had basically 5 minutes to unlearn what they had seen, to explain to them they needed their brains, not PPE. I see the red light flashing. I'm ignoring it. All right? To do this. And I made the mistake afterwards of taking out my hand sanitizer and cleaning my hands. I was nearly mobbed because people thought that was magic hand sanitizer from Switzerland, as opposed to what they got. No, but these are, every moment you learn something if you're aware. We convened 60 stakeholders after Ebola, after 2 years. This was in November 2015. And we agreed on these 7 lessons, right? By this time, nobody doubted community engagement had to be central, risk communication had to be central. But of course, everybody admitted, and this is my job at global level, not just to look at success stories, but to be responsible for what went wrong. It was too fragmented, it was too little, too late. And there was a big disconnect between the biomedical and social sciences, communications and community engagement. There were lots of sociologists and anthropologists in the field, but they didn't know how to talk to program managers systematically with real-time information, right? So this was a very big problem. Responders and community, you were part of the problem. If you went in, you were seen as an alien. Culture of pushing messages, regardless of all of this, everything everybody has said that we listen, we craft, we are flexible. No, we all pushed messages. And you mentioned earlier about branding. People were carrying their flags, you know, mandate clash. So this was a very difficult time for the international system. Look at this. There's studies that show Zika, when Zika communications is mixed together with dengue and chikungunya, all 3 diseases suffer. But we continue to do it. We continue to do it because it makes sense for us. So what worked? I think the global multi-partner coordination strategy, very, very quickly, within the first 2-3 days, when something big happens, my job is to go into incident management, convene the partners, and then decide the big blocks of response. For the first time ever, 50% of the budget for the global response for Zika was risk communication and community engagement. This had never happened before. It was not for me, it was for everybody. Okay, resource packs and so on. Okay, yellow fever, I talked about yellow fever. I won't talk about it now. Okay, the international health regulations basically is an agreement between all partners, all countries in the world, authorizing WHO to do certain things. Receive information, investigate, declare public health emergencies of international concern, and give travel and restrictions, right? The core capacities, risk communication was there, but for many years, it was member states, governments themselves assessing their own capacity. This was not reliable at all. If you look in 2015, member states reported, generally they had 82% of risk communications capacity covered, right? But now everybody agrees this is not a good way to do things. So they've added some new things, including exercises, after action reviews, but something called joint external evaluations, where people from outside go in, join a team from the country, and honestly evaluate. So this is the evaluation. This was before, or at the time of Ebola. This is how Guinea, Sierra Leone, and Liberia had assessed their risk communication capacity, all right? which shows you that this is meaningless, all right? So that in the new system, we are proposing for systems 5 blocks. Risk communication systems to develop national strategies, plans, structures, resources, standard operating procedures, and exercises and simulations to test that. Internal and partner communication and coordination as the second most important block, that unless you have identified stakeholders in country and you have coordination mechanisms before emergency, you're not going to do very well during an emergency. Mechanisms for public communication to reach your audiences, their channels of choice, not your channels of choice. Communication and engagement with affected communities, and systems for dynamic listening and rumor management. So these, in the green are the countries where the JEs have been completed. The USA volunteered right at the beginning to set an example. That was excellent. And you can see many more are planned. Okay, you see the difference. Let's go to the USA. In blue, for number 8, which is risk communication, you see that the self-assessment was this much, and the JE was much higher. In fact, the USA had underestimated its capacity. But you see, it's not the same in all countries. So what are the 5 directions that I propose that you take? We need to build the evidence base for what we do and move from what we like to do to what has proven evidence. To this effect, UNICEF, us, everybody, we are collaborating on developing the first evidence-based guideline for risk communication capacity building. We need to involve all of government, not just the health sector or the agriculture sector. We have to involve everybody. We need to show decision makers the cost of not investing in risk communication. This is a particular skill and it needs a particular data set. So I've teased it out all on its own. So the technical, the biomedical has to be sound, the facts have to be sound, but we need to have operations to scale up, right? In Ebola, I was put in charge of training. I was told I had 8 weeks to train 110,000 people, frontline responders. That is a scale we're talking about today. And we need to match with money and people. No money, no place at the table, no people, no place at the table. And I mean at the high table, not at some small table in the annex. So operational, technical, and social. And this is how we visualize it, but Rafael will be very angry with me if I spend time on that. Okay, this is what WHO is investing in systems. We are investing in translational communication. So we will have knowledge packs that frontline responders and decision makers can use on most of the known and emerging pathogens, all right? And these will be available on apps, in informal ways, in hard copies and others. Knowledge transfer, I've just opened a new platform called Open WHO, which can host 250,000 users for interactive learning and briefing at any given time and can be scaled up to unlimited numbers. Surge capacity, I already have an emergency communications network. I'm developing a social net, a network of social scientists and anthropologists, and I invite you all and your agencies to take part, who learn how to work in a response with incident managers and epidemiologists and others. We've got the guideline coming, and we take part in the joint external evaluations, the national planning, and the testing. I should stop, right? This is what my pretty platform looks like. Please use it out when it comes out. Thank you very much, and apologies for going over time.